there's the preamble. This is developed as an evidence-based presentation to share with our community here and to guide a discussion. I'm actually most excited for the discussion that's going to follow afterwards. And this is, again, I'm a specialist in internal medicine, so I wear lots of hats. I look after COVID people. I manage the the COVID workflow in hospitals, responsible for overseeing the administration of biologics and therapeutics. And then obviously as an academic doctor and one who works in a rural and a downtown center, I've seen the impacts of COVID on everyone from the patients, the hospitals, the staff, and the learner. So that's a part of the conversation today. And so I say surfs up, and what's funny is when I was creating this talk, I was looking through my plethora of presentations I've given in ECHO coping with COVID. And I think I've talked about each wave. So I'm running out of names and I'm getting sick of each wave, but we are now on the downward trend of the sixth wave. And I am going to go over with each of you some of the things that are important to recognize about this wave, and also some of the things that we've learned over the course of the past 2 years that we can apply to keep ourselves safe and keep those that we care about safe, whether those are family members or patients. And then talk about some of the things that keep coming up, like does the vaccine work and what about reinfection? So I'm going to go through this in a general form and kind of reorient people to where we are right now. As I ripped through those earlier slides, I have no conflict of interest to disclose. This is purely based on evidence. It's meant to be informative and to guide a stimulating discussion afterwards. So March 21st, everybody remembers this, and we won. So the provincial and federal government declared our victory, and we're going to get rid of masks. We're going to get rid of limits on capacity, and we're going to get rid of vaccine passports because we've won. And I have a screenshot there just to remind us on March 21st. We can see my buddy Brooks Follis there in the bottom left. We have a lot of physicians smugly smiling that we never really won at March 21st. There was just a collective decision made by the government to change restrictions. And I think for all of us here, we obviously kind of understand the competing priorities and factors that, sure, shutdowns limit the spread of virus, but shutdowns impact one's mental health. They're bad for business. So there's no easy way out of this, and there's no right answer. But did we do the right thing on March 21st? The jury is still out. What does COVID do? We've now had 2 years, and a part of this sixth wave review is what does COVID do to our bodies, right? And with each successive variant that is introduced, different things happen. But COVID causes direct vascular trauma and vascular inflammation. It impacts all of our organs. Historically, when COVID first came about in the initial wave, it was predominantly a respiratory ailment. But then we started to learn a lot of interesting things that were happening down the line. And I know Javed spoke about this with the long COVID discussion related to renal disease down the line, much higher risk of myocardial infarction, much higher risk of congestive heart failure, a lot of autoimmune and immune-mediated impacts on the gut and on the nervous system. And what we've seen with the more recent viruses, the more recent variants are more of an upper respiratory tract, a lot of different symptoms. Headache is now one of the symptoms. So COVID itself wreaks havoc on our body, and it impacts us all throughout by virtue of significant inflammation. But depending on which variant we are and which season we're in, the manifestations will be different. But we have learned that this is not a quote unquote benign virus. And this is not just the common cold, right? Which everyone is hoping for right now. But the evidence to date does not suggest that this is what we're dealing with. So we talked about the impact of COVID and how it changes. And since this started, right, this was our third April-long weekend in 2 and a bit years that the heavy gray cloud of COVID rested over our heads, And my wife and I were looking at the photos on our Google Maps display and all the pictures that come up. And this day a year ago, this day 2 years ago, pictures of our kids learning on the internet, pictures of us going crazy on yet another weekday with all the kids stuck at home because there was nowhere to go. Holiday dinners spent alone with your immediate family only, because of fear of having other family members over, and also because of repercussions, right? Groups no larger than 10, you'd be ticketed. So we've lived through this, and we've lived through COVID, but in many different wave shapes and forms, right? We had the original COVID that came out, the wild type that mutated. We had Alpha, then we had Delta, and now we have Omicron, we have BA1, BA2, and now people are talking about XE. So the current variant that we're dealing with now in wave 6 is the Omicron variant and the BA2 variant, which is giving a different constellation of symptoms. It's still COVID, right? Still has the similar spike protein genetic makeup and the impact on the body, but the manifestations are a little bit different. And I suspect that in 10 years, if we still have coping with COVID and I'm giving this presentation, this curve will continue to go upwards and downwards with various variants over time, because this is what viruses do. But when we look at some of the numbers and the impact, and this is what mediates and leads to some of the decisions, we can look at this graph here demonstrating the cases that are hospitalized overall in the province and the cases of COVID patients that are admitted to the intensive care unit. And if you look at the peak there between January and March, which was the initial Omicron peak, we had that was that huge surge, and hospitals were burnt out and hospitals were full. The whole term of incidental COVID, your COVID swab is positive, but you're here with a heart attack. So is it an incidental COVID, or did COVID give you the heart attack? So we're still trying to tease through that data and understand, but we do know that the systemic inflammatory response and vascular insult of COVID can lead to a whole host of other medical conditions, which likely contributed to those admissions. But we met a significant peak there. And unlike the prior variants, where there were larger peaks in ICU admissions relative to hospital stays, this one wasn't so bad, but it was still bad. And it happened during a time when people were burnt out and stretched thin. And so looking at where we are today, now this is effective as of yesterday, we can see that the hospital occupancy has increased, but not as high as it did earlier in the initial Omicron peak. And ICU volumes have remained relatively static. But when you look at this, if you were to take this graph and overlay it with the cases, which we don't have good information about right now because we're not necessarily testing, the volumes of admissions in hospitals and ICUs generally happen after the case count surge. So we would expect these case counts to continue to rise. These are the specific numbers here. And I think it's quite helpful just to look at the data on the vaccinated people. The three bottom categories that we can see here, I don't know if you can see my cursor, demonstrate that the reduction in COVID associated with at least 2 vaccine doses is significant. And when you look at the proportion of people admitted to hospital who are unvaccinated, and you think about how few people in Canada are unvaccinated at this point, we've done a really good job. You can see the benefits of vaccination are still quite strong at mitigating critical disease, admission to hospital, and length of stay. We're done testing people. We're not doing PCRs on everybody. You have to be in a special club to get that, which is generally a healthcare worker admitted to hospital. We have these rapid antigen tests that are okay, and I'll get to that in a little bit in terms of their validity. But what we're trying to do now is use other surrogates to identify where we're at in these peaks. And to be truthful, I actually feel that wastewater signals are a much more effective way of monitoring these peaks and valleys, because with the PCR swabs and the rapid antigen tests, unless you're testing everybody every single day and testing them properly, you're only looking at results for people who did the testing, and then you're at the mercy of the sensitivity of the tests. And so what's been taking place for the last 6 months has actually been looking at wastewater data from the various public health regions in Ontario and throughout the GTA, and looking at wastewater signals, which are evidence of the viral density in wastewater. And this correlates quite nicely with case counts in the community. So everyone is collectively holding their breath that we met our peak, about a week ago, and things are plateauing and will go down. Obviously a lot of apprehension around the April long weekend if this impacted further spreads. And what's going to happen. But like all of our waves, they come up and they come down. And it looks like right now in the sixth wave, we're seeing ourselves to the other side. Fortunately, when we look at deaths across the province, we really haven't seen a significant increase in deaths attributed to COVID at this point. But then again, if you look at that peak, if I were to overlap that peak with the prior graph, which was the case counts in the province and hospital admissions, the deaths generally follow the admissions and peak in volumes. So this will be a very interesting thing to watch evolve over time, because that narrative of, oh, COVID is just the new flu and I had a sore throat, but I worked through it. It seems like a lot of people do have a mild illness. And what we've learned about the Omicron BA1 and BA2 variants is it's much more of an upper respiratory mucous membrane type illness. But when you look at all comers and you look at people with medical comorbidities, frail, advanced age, the outcomes may very well be different. And so we'll really get a better idea as to whether or not this current variant is the quote unquote common cold or not. And that will have to follow over the months of May, which is generally when the death rate is reflective of peaks in the case counts. So I felt that echo coping with COVID, it's very important to talk about what this has done to all of us. And, I talk about the viral impact on the blood vessels and the heart and the lungs. And, that's what brings people into hospital and that's what makes people feel unwell. But how is this hospital and how are our clinics dealing with this? And burnout is the buzzword right now. PTSD is the buzzword right now. This collective feeling amongst healthcare workers that the government, quote unquote, let this rip and said the healthcare system can handle it. And as somebody who works in the healthcare system, it can't. The ICU is barely able to keep their staff. They don't have enough nursing staff to staff the ICUs. Right now at Toronto General Hospital, I think about every internist has had COVID. We got to the point last week when if you were feeling well, there was no one to replace you because everyone who could replace you was off with COVID. We had a few days last week where close to 70% of the residents and fellows were off with COVID. And this is not people who were off because they may have had a contact. These are people who had COVID because the rules for being sent home from work have become a lot stricter because we're desperate to have that staff. So the situation is quite concerning within the hospital walls, within the clinic walls. And I know that the hospital is one environment and a lot of industries are experiencing high amounts of staff absenteeism, but definitely the hospitals are being impacted here. When you look at this happening across hospitals, across all lines of work, impacting the people who are coming into hospital, a lot of tense and irate behaviors, people, both healthcare workers and patients visiting the hospital and family members, everyone has a short fuse and everyone has been impacted by this. We're seeing crises in paramedics with record time off of work. And imagine the uncertainty of being called to all these short of breath people and now having to put on N95 masks and gowning and gloving and going to see every patient, dealing with the same staff absenteeism, being mobile in this small moving van with a sick patient in the back. Wow, that is stressful. So nobody is spared in all industries, but the healthcare industry and community has been significantly impacted in a detrimental fashion by this. And we're just starting to see the tip of the iceberg here. Moral injury is felt to be described similar to what's experienced in veterans and the shock and horror of serving in the military and seeing awful things happen at war is creating similar downstream impacts of having worked in healthcare. And this was a study published in one of my journals in the Journal of General Internal Medicine that demonstrated this. So there they are, those spike proteins and our friend COVID. So what do we know about this now, right? We didn't know much 2 years ago. We wore masks. I was washing my shoes and pants every day I came home from work, sanitizing the car. What if I was going to get everyone sick? Well, we've learned that this virus transmits itself through respiratory droplets, right? That move about when we talk, when we sing, when we cough, when we laugh, when we sneeze, when we shout. And if you think about the places where this happens, concerts, packed venues, bars, dance clubs, probably not happening if you're alone in your basement. But I put that out there because now that we understand how the virus is transmitted, you can make decisions about where you want to be and where you don't want to be. Well-ventilated spaces have much less droplets hanging around than unventilated spaces, and obviously being outdoors is optimal. So understanding things like air windows open, having HEPA filters in the room, even things like carbon monoxide detectors, which help to give a good idea, or carbon dioxide detectors, sorry, not carbon monoxide. Carbon dioxide detectors in rooms can give a good idea as to the degree of filtration and ventilation. And I think you'll start to see more rooms equipped with carbon dioxide monitors to allow one to know how safe that room would be from a viral transmission standpoint. And this is something that epidemiologists are asking for throughout the province. As we know, droplets can stay on surface, don't seem to happen that long, but if we touch something with those droplets and then we wipe our nose or wipe our face, that's how you can transmit these viruses into our mucous membranes and make ourselves sick. So everyone and their dog is trying to get a passport now because on March 21st, we declared the end of restrictions and, we're overcoming COVID. And I say that tongue in cheek, but how can we apply these principles of viral transmission to the various environments where we're going? Well, what's interesting is air travel and viral transmission has been studied quite well. Airplanes have excellent HEPA filters, so actually about the same as the ones you'd find in an operating room. And the airflow that happens through the airplane cabin, although people talk about the stale air, there's actually very good airflow moving across the seats without much forward or backward airflow happening. So what that means is if you're on the plane, you're not likely to pick anything up from the people behind you or in front of you. If anyone is symptomatic or transmitting, you're likely to get it from the people sitting next to you on either side. Same thing would apply on some of the public transit buses, TTC, subways, etc., where similar airflow principles apply. And this gives you an idea of how you would want to mask up, how you would want to wash your hands, how you might want to be careful depending on who's sitting next to you. And you can use that information as you will, but there haven't necessarily been any significant outbreaks or cases linked to air travel itself, to being on the airplane, interestingly enough. It's more associated with some of the other congregate areas, getting to the airports, in the lineups, moving through, etc. That is associated with case count rises. We've done a ton of work, and if you look at Public Health Ontario and on the federal government website, we've done a lot of work looking at public transportation to see how safe is it. Should we be wearing an N95 mask on public transit? Should we be opening our windows? Should we not be taking it? And I like looking at the public health website because this is a very robust way of looking through all of the literature and peer-reviewed publications, comparing that with international and national guidelines to come up with an understanding of what we can do if we have to take public transit to get to work, if our patients have to take that to come to see us and we want to keep them safe and comfortable. There's excellent and robust data that outlines how we can do that. And it comes down to social distancing. It comes down to wearing a mask, regardless of if it's to prevent yourself from infecting others, but also to protect your face from breathing these droplets and from rubbing them on your face, and frequent hand washing and sanitation, keeping the windows open, and trusting the ventilation in subways and streetcars, which is equivalent to that in airplanes. So those are some things that you can do or your patients can do to protect yourself. But what are some other ways that we're going to protect ourselves? Well, vaccines, right? And what frustrated me as a healthcare worker on March 21st is we declared the pandemic over. And that in a way, it kind of said that these vaccines aren't doing much. But these vaccines are incredibly effective. And if you look at the data up until yesterday, unvaccinated people are far more likely to end up in hospital and far more likely to have severe disease. But does the vaccine work against the current variants? So yes, they do. So these vaccines do work against Omicron, but the immunity tends to wane. in a much shorter time frame. And you're looking at several months. And this is why there's conversations around a fourth booster shot, new vaccines specific to Omicron and other subvariants. So yes, the vaccines work, but the longer out you are from your third dose, the less effective these vaccines are. And so we're starting to learn more about this phenomenon as time evolves. What about reinfections, right? This is all the rage. So reinfections are not that common, but they happen when you have two variants circulating around. So we have Omicron, let's just say instead of BA1, BA2, Omicron 1 and Omicron 2. Because these are predominantly mucous membrane, nasal, upper airway, what happens is when you have your immune system responding to something, which is what the vaccine is intended to do, this is your bloodstream immunity fighting back against something, creating a response. When you get these viruses in your upper airway and the mucous membranes, the immune memory in those areas in the mucous membrane is much shorter than in the blood. And so your immune system will activate to fight this Omicron, Omicron 1. But then the immune memory wears off. And then if you get exposed to Omicron 2, BA2, your immune system in the head and neck doesn't recognize that as well as your systemic immunity. And that can lead to you getting symptomatic twice. But in general, reinfections are far milder. Reinfections are not that common, but reinfections, especially when you get two variants at the same time, is what can lead to new mutations developing. And there is a lot of emerging evidence around the XE variant, which has come up in London and has come up in Australia, which seems to be a combination of these two variants, but generally gives the same type of symptoms, mostly upper respiratory tract infection, sinus, headache, etc. So this is the XE variant, which seems to be the result of these reinfections and getting two variants at the same time. But again, not that common yet. Wouldn't be surprised if this becomes the dominant strain in the coming months. So outside of, well, you've done your vaccination, but it might be wearing off. You're wearing a mask, you're washing your hands, you're avoiding these closed spaces, you're opening windows to ventilate things, you're being careful where you go. But if you're a young and otherwise healthy person, well, to be honest, you don't have that much to worry about. You probably won't die from COVID. You might get long COVID, and the evidence is coming out about that. You're probably going to have a mild to moderate illness course, which is self-limited, but not everybody is young and healthy. Many people have other medical conditions, have extremes of age. And if you go to the alberta.ca website, there's a lot of wonderful what's my risk websites, and CDC has one. There's a federal one. Some of the universities in the States have created them. Alberta's is excellent because you can go there and you can put in demographic information, health information, medical information that can let you know what your risk is if you were to get COVID of ending up in a hospital or getting severe complications. And I'd encourage you to direct your clients or family members to arm themselves with this information so they can better understand what their personal risk is, and then they can decide where they want to go and what risks they want to expose themselves to. So as I've mentioned, we mitigate that risk by all of these wonderful things that we learned: washing our hands, wearing a face mask, avoid touching our nose and mouth, by bringing those droplets out there, wash any shared surfaces, and most importantly, avoid going out if sick. On the public transit, trust the ventilation systems, recognize the principles of viral transmission, use them to decide if you're comfortable getting in the streetcar or the subway, maybe travel during off-peak hours. Make sure to wear that mask and practice good hand hygiene. And if you're uncomfortable, get off. I hope, if anything, the one thing that we get out of this sixth wave in COVID in general is a better recognition about when we shouldn't be at work and exposing others around us, including our patients, to illness. If you're feeling unwell, stay home, right? That's one of the most important things you can do to prevent viral transmission. And I hope that the workplace habits and cultures sculpt and change in that general direction. If you do think you're sick, you can use a rapid antigen test. We have many of them in the hospitals. Anyone with school-age children has access to it, but use them with caution, these rapid antigen tests. What happens is most of us are vaccinated. So what happens when we get symptomatic from COVID, we get the symptoms, but that's our immune memory recognizing things because of this wonderful vaccine. But the viral load doesn't get high enough until a few days into your symptoms to actually give you a positive RAT. So this demonstrates the positivity of rapid antigen tests following the first positive PCR test. So you need much higher viral loads to get a positive RAT. And so if you think that your symptoms are getting worse and that you may have it, the initial RAT may have been negative. So use that with a vein of caution. Recognize too that just doing the nasal swabs for Omicron misses about 30% of positive infections. And so now the instructions are, if you're going to use a rapid antigen test, to swab both cheeks, swab your throat, swab both nares, and then shut your nares and twist them, and then test it. And test it as your symptoms continue, because the positivity chances will increase as time goes on. So a negative RAT doesn't necessarily mean that you don't have COVID, because a lot of positive COVID sneaks through that. And it goes back to, if you're sick enough that you're doing RATs, you probably shouldn't be going to work or going to the nightclub. We have a medication, Paxlovid, which is out now and good at preventing people from going from mild to severe disease. It's a protease inhibitor that actually stops viral replication of COVID in its tracks. And this is a quite effective medication at reducing hospitalization. And of all of the treatments out there, it's one of the safer ones to use in patients with renal disease, liver disease, and who are pregnant and or breastfeeding. We have wonderful guidelines that change almost every 3 weeks on the Ontario Science Table, where if you're in practice and you say, I wonder if this person should be placed on this antiviral, there's a straightforward algorithm to decide based on vaccination status and risk factors if this person would qualify for that medication. We have FLUVOXAMINE, shout out to our psychiatry colleagues, which has demonstrated an effective response at decreasing the duration of symptoms and severity of symptoms. The instructions for dosing and criteria are also on the Ontario Science Table website. Finally, with all the impact on all of our healthcare workers and colleagues and our patients in life, take time to be kind. Everyone is short-fused, everyone is stressed out, everyone's anxious about the future. I think that's normal. It's been quite the interesting 2.5 years. Kindness helps. And I think regardless of where you're working and who you're working with, take time to connect with people, to be grateful for people, and find the positive parts of our day, because like every other wave, this wave will be over soon. Other variants will come. We can only hope that they become milder and milder over time. We can continue to rely on our system to create effective treatments for this. And we can hope that our government will recognize some more helpful strategies to mitigate the spread and growth. So thank you very much for your attention.